Peace be upon you. This is Dr. Ahmed Farag, consultant cardiac anesthesiologist, and this talk is about pathophysiology of shock. I have no disclosures. By the end of this talk, I will discuss basic physiologic principles of shock, types of shock, and pathophysiology of each type. This is a contracting heart, and if I freeze the largest size of this heart, I will reach the end diastolic volume. And if I freeze the smallest size of this heart, it will give us the end systolic volume. End diastolic volume resembles preload of the heart, while end systolic volume resembles the interaction between contractility and afterload. If I subtract end diastolic volume minus end systolic volume, it will give me the stroke volume. And let's take an example for that. Stroke volume, usually in a normal adult, is about 70 milliliters. And if the end diastolic volume is 120 milliliters, the end systolic is 50. And if we divide stroke volume by end diastolic volume, 70 divided by 120, it will give me 0.58, and this is the normal ejection fraction of an adult. Stroke volume comes with every beat. So if we multiply this with the heart rate, that is in average 70 beats per minute in a normal adult, it will give us the cardiac output that is about 4 liters or 5 liters in a normal adult. And if we multiply this cardiac output by systemic vascular resistance, it will give us the blood pressure. And if we arrange this equation, so blood pressure will equal cardiac output multiplied by systemic vascular resistance. And as we said before, cardiac output equals stroke volume multiplied by heart rate. And the determinants of stroke volume that we discussed in the beginning of this talk are preload, afterload, and contractility. So this is the last equation that we will follow throughout this talk. Now let's talk about types of shock. The shocked patient could be in hypovolemia. So this is a hypovolemic shock, whatever the cause of this hypovolemia, hemorrhagic or dehydration or whatever. He could be in cardiogenic shock because of left ventricular or right ventricular failure. He could be in distributive shock because of anaphylaxis, neurogenic shock, or septic shock. And he could be in an obstructive type of shock, including tamponade, tension, pneumothorax, pulmonary embolism, and hypertrophic obstructive cardiomyopathy. What we face in the perioperative setting, in a study done on an adequate number of patients in the perioperative setting, the most prevalent causes of shock were left ventricular failure, hypovolemia, and right ventricular failure. So if we just assess the ventricular function and the volume status of the patient, we will be able to diagnose about 80% of causes of shock. And this is important. In each type of shock, we will discuss two items: what happened in the patient and how the body compensates for this pathology. And let's start with cardiogenic shock. As obviously you can imagine that the cause, what is the derangement in cardiogenic shock regarding our equation is the problem in contractility. So whether left ventricular or right ventricular, if the ventricle is not contracting, the patient will be in shock, in cardiogenic shock. For example, these are the numbers that we gave as an example for normal in the beginning of the talk, and this results in ejection fraction of more than 55%, and this is normal. In cardiogenic shock, we note that the stroke volume is low because the heart is hardly contracting. And when the stroke volume is low, this means that the heart cannot pump the amount of blood accumulating behind it, the venous return. It cannot pump it adequately through the left or right ventricle. And this makes the preload accumulate behind the heart. So the end diastolic volume increases. And because of the weak contractility and the low stroke volume, the end systolic volume also increases, and this results in a low ejection fraction. This heart will look distended because it cannot manage the preload that it needs to be pumped through this heart. Okay. The next type of shock is the obstructive shock. And as you see, these are the most common types of obstructive shock. And if we focus on these types, we'll find that tamponade and tension pneumothorax are external causes, and this cause a sort of impaired filling of the heart. Hypertrophic obstructive cardiomyopathy is an internal cause, and this cause impaired emptying of the heart, while pulmonary embolism has a combined pathology, as we will see soon. Let's start with tamponade. And tamponade simply is an exaggeration of pericardial effusion that compresses the cardiac chambers, and this prevents the heart from adequately filling. If the heart cannot fill well, this means that we have a problem in the preload. How the heart compensate for this derangement? It starts to the body starts to excrete its own catecholamines, and this makes the heart contracts stronger and faster. For example, this is the normal number examples that we had in the beginning of the talk, and in obstructive shock like tamponade, we will note that the end diastolic volume is low, the end systolic volume is very low, and the stroke volume is still lower than the normal, despite the exaggeration in ejection fraction caused by the endogenous catecholamines. The next is tension pneumothorax. And the pathology in tension pneumothorax is mainly the loss of the negative intrathoracic pressure. This negative intrathoracic pressure is crucial for the venous return, and once it is lost, we will have dramatic drop in the venous return. What do you think will be the status when it is positive? It is not just loss of the negative pressure, it is positive pressure in the thorax, and this will prevent venous return from coming back towards the heart, and this will affect definitely preload. With exaggeration of the tension pneumothorax, there will be some push of the mediastinum and great vessels to the other side of the thorax, and this may cause kink of the great vessels, but you can think that this is a very, very late stage, and this pathology is not the most common cause of hypotension or shock during tension pneumothorax. So what is affected in tension pneumothorax? It is preload mainly. Okay, next is pulmonary embolism. And what happens in pulmonary embolism actually is an embolus that obstructs the way of the right ventricle. The right ventricle is not designed to tolerate high pressure. This embolus causes sudden or acute increase in the afterload of the right ventricle. And because the right ventricle is not designed to tolerate high pressure, acute increase in blood pressure, in afterload, I mean, the ventricle will distend, and its contractility will fail acutely. So acute failure of contractility and distension of the ventricle. With distension of the ventricle, you will find the interventricular septum is being pushed towards the left ventricle, and this causes impaired filling of the left ventricle. So the problem starts with sudden increase in the afterload of the right ventricle. This is followed by weakness of the contractility of the right ventricle or right ventricular failure, and then drop in the preload of the left ventricle because of the ventricular interdependence, or the pushing the septum, the interventricular septum, towards the LV that affects preload of the left ventricle. Okay. Next is the hypertrophic obstructive cardiomyopathy. And to understand what happens in this pathology in hypertrophic obstructive cardiomyopathy, we need to know the normal. And normally, when there is ejection, the blood goes through the aortic valve from LV to the ascending aorta, and the blood flow is parallel to the interventricular septum. In hypertrophic obstructive cardiomyopathy, the septum is enlarged, and this causes the blood to move from the LV to the ascending aorta with some deviation towards the mitral valve. And because the anterior mitral leaflet is on the way of the flow, it is got on the flow. So it is dragged with the flow of the blood from LV to the aorta. Dragging of the anterior mitral leaflet causes obstruction at the left ventricular outflow tract and the sudden closure or discontinuation of the stroke volume. Also, as you see here, it causes some mitral regurgitation. So the pathology in hypertrophic or obstructive cardiomyopathy is quite complex. It starts with sudden acute increase in afterload caused by the systolic anterior motion of the mitral valve that obstructs the left ventricular outflow tract. And also this affects and gets affected by the preload. It affects the preload by retaining some blood in the left ventricle because of the decreased emptying, and retaining also regurgitation into the left atrium. This volume affects the preload. And on the other hand, if the patient is fasting for a long period of time, the septum will move more and more towards the mitral valve, and the blood will drag the mitral valve more and more, so the obstruction will be more aggressive. Next is the hypovolemic shock. And to imagine hypovolemic shock, I want you to focus on this image. It is very interesting because hypovolemia is not necessarily blood. Any loss of volume, of the circulating volume of the patient, is considered hypovolemia, despite the most common cause is hemorrhagic shock. But it can happen with any loss of circulating volume, like aggressive diuresis, for example, or diabetes insipidus, or massive GI loss, for example. What happens in hypovolemic shock? Obviously, it affects the preload. And if we have this example of normal numbers, in hypovolemia, we have very low end-diastolic volume. And the body will compensate or try to compensate with its own endogenous catecholamines that will increase contractility and heart rate. So with increased contractility, you'll find that ejection fraction is exaggerated. For example, it reaches 80 or 90%, and the end systolic volume is very low. However, the stroke volume have markedly dropped in hypovolemia. Whatever the compensation, hypovolemia is very aggressive and it can drop the stroke volume aggressively. The final type of shock is distributive shock, and the most common examples of this type of shock are anaphylactic, neurogenic, and septic. Of course, this discusses the early or the very early stages of sepsis, because shock in sepsis is a complex pathology. So if we have these pathologies, what happens in all these pathologies are vasodilation. Acute severe vasodilation causes drop in the systemic vascular resistance and the afterload of the heart. For example, if we have these normal numbers in distributive shock, initially the end-diastolic volume will not be affected. What happens is vasodilation. So with the normal contractility of the heart, you will find the heart emptying more and more because there is no resistance now in front of this heart. Systemic vascular resistance is low. So the contractility, the same contractility, will empty the heart more. So the end systolic volume will drop to like 10, and you will find exaggerated stroke volume and exaggerated ejection fraction. If we compare these numbers to the numbers we just discussed in hypovolemia, the end systolic volume is the same on both. Ejection fraction is exaggerated on both. Stroke volume, however, is much less in hypovolemia. And the most important and diagnostic factor is the difference in end diastolic volume that in distributive or early distributive is maintained almost near normal, but in hypovolemia it is the most affected parameter. After a while, distributive shock does not remain like this because of the dilation of capacitant vessels. This causes a sort of hypovolemia because the blood will go to capacitant vessels and it will stay there, making relative hypovolemia in these patients. And if you compare these numbers, the new numbers of distributive to hypovolemia, you will find it very difficult to distinguish between both types. So, what do you expect when I tell you that the patient is hypovolemic? How is the contractility of the heart and the filling of the heart? When the patient is hypovolemic, I expect that the heart will look empty and will be well contracting. What about cardiogenic shock? In cardiogenic shock, I expect the heart will be full and weakly contracting. In distributive shock, I expect the heart will be full and well contracting. And in obstructive shock, I need to find the source of this obstruction. In real life, it does not go like this. For example, if we have a patient that is in ischemic cardiomyopathy and is undergoing thoracoscopic lobectomy, he received antibiotics and multimodal analgesia. Then, with the initiation of surgery, we find significant blood loss. Can you tell me what could be the possible cause of shock in this patient? It is very difficult to distinguish. Actually, sometimes it will be a mix between all of these types. And this is the importance of point of care ultrasound or focused examination to distinguish between all these types of shock. And that's it. This is everything. Thank you very much.